All right. This is Kathleen Thomas, and this is an update on the changes to the 2021 Advanced Trauma Life Support. So initial assessment, move to blood products as soon as possible. Standards are changing due to evidence-based research. Uncontrolled hemorrhage is now treated immediately after establishing scene safety, and it is done before addressing airway. The golden hour is not a strict 60 minutes, but a concept used to emphasize the importance of transporting trauma patients as fast as possible. The major cause of potentially preventable life is uncontrolled hemorrhage. Restriction to only infusing 1 liter of IV fluid, which is usually normal saline, which this is a big change. Infusion of more than 1.5 liters of IV fluid has been now shown to increase mortality and trauma. Massive transfusions are now recommended, like 4 units of blood in 1 hour or 10 units in 24 hours. Large amounts of IV fluid can cause dilutional coagulopathy, cardiac complications, electrolyte imbalances, and hypothermia. Airway and ventilation. Short-acting drugs used for intubation with gag reflex, and that would be something like propofol or ketamine. And you would use something like this and decrease level of consciousness, intoxication, traumatic injury, and the inability to adequately ventilate non-invasive ventilation, like bag valve mask or something. The main side effect of using these medications is low blood pressure. A new thing that we've had for a couple of years, which is now used in the ambulance and everywhere else, is video laryngoscopes, which are really cool. They're little handheld laryngoscopes, but they have a light with a video on it, so you can watch the ET tube go through the vocal cords, and then you're intubating in the right place. And here's a picture of it. So it's great. And so, when you're putting that in, you're trying to be careful of the teeth, and you don't have to look away. You just look right at that little screen. Shock. Shock is a lack of oxygen to organs and tissues. I'm going to go over the different types of shock. Hypovolemic shock, which is lack of blood. Anaphylactic shock, which is allergic, like a bee sting or something, or maybe somebody ate peanuts. Septic shock is an infection, usually bacterial. A neurogenic shock is from head injury. There's also cardiogenic shock, is when the heart can't pump properly, like if somebody had chest trauma and they had cardiac tamponade, where the pericardial sac fills up with blood and then the muscle can't contract properly. No matter what type of shock it is, it presents the same way. Increased heart rate, decreased blood pressure, cool, pale skin, restlessness, anxiousness, and possibly unconsciousness. Something new in shock is tranexamic acid, and it's a IV infusion, and some people, probably paramedics and stuff, carry this. It works by slowing down the breakdown of blood clots, and it's recommended to be used within 3 hours. And this would be, in a big trauma patient who's bleeding. The side effects of it are deep vein things that cause clotting, deep vein thrombosis, pulmonary embolism, and stroke. In the field, you can control shock by controlling bleed, or you can decrease shock by controlling bleeding, high flow oxygen, prevention of heat loss, and rapid transport. Thoracic trauma. The term flail chest has been replaced by tracheobronchial tree injury, which is a mouthful. Life-threatening thoracic injuries include tracheobronchial tree injury, which is flail chest, which is a fracture of 3 or more contiguous ribs, airway obstruction, tension pneumothorax, open pneumothorax, or massive hemothorax, like cardiac tamponade. And now I'm going to show you my video of flail chest. Okay, here it is. You can see the paradoxical motion of the chest. When he's breathing in, it's going down instead of up. And I think that video is good because that's something that, like if somebody crashed in the park and landed on their chest, you could easily just put your hand on their chest. And if both sides are not rising with inspiration, you can think, okay, they've got at least 3 rib fractures. Needle placement to decompress pneumothorax has changed. So in adults, it's now the fourth or fifth intercostal space mid axillary line. In kids, it's still the second intercostal space mid clavicular line. And here's a picture of that. And I think a lot of people have been moving more towards that, the fourth or fifth intercostal space on adults. Abdominal and pelvic trauma. Prostate exam is no longer recommended when you're trying to decide if someone has a pelvic fracture. So everyone can stop doing that. Pre-peritoneal pelvic packing is included in the hemorrhage protocol. Pelvic packing is done in hemodynamically unstable severe pelvic fractures. And that is done in the operating room. They cut the abdomen open, they move the bladder over, and they pack sponges between the pelvic ring and the peritoneum. Looking for abdominal injury and unexplained shock. Look for Gray-Turner sign is flank bruising. Here's a picture of it, and that's from sub-Q blood running under the skin. Here's a couple other pictures of it. And now my abdominal wound packing. So Sue, did you get this?
No, keep going.
Okay. Here's a video of my abdominal wound packing. I did this last year, but I thought it was pertinent, so you get to watch it again. This is my pork shoulder with a very deep wound. This wound is too large and too deep to just apply direct pressure, so I'm going to have to pack it. There is a lot of blood in the wound and I cannot see the bottom. I am going to do a quick finger sweep. There's some squirting blood, but I can feel the bottom of the wound. So I'm going to take my Kerlix. You can pack it with Kerlix or you can pack it with gauze 4x4s, but I happen to have this and this is easy to remove once they get to the hospital. So I'm going to just pack this in the wound as tight as I can. By doing this, it applies pressure to the little tiny arteries and puts pressure on them so they stop bleeding. So I'm going to pack it tight as I can. And then I'm going to put a compression dressing on it. Hold direct pressure now that it's packed. I'm going to hold direct pressure till it quits bleeding. If it keeps bleeding, I will just add more 4x4s. When it stops bleeding, I'm going to continue to hold pressure while one of my co-workers wraps Kerlix around the wound. If it's too big to wrap Kerlix around it, you can put a 4x4 and try to create pressure that way. Continue holding direct pressure till it stops. And something I thought of after I did this video is instead of cutting that roll of Kerlix off, you can leave it on top of the wound and then stretch your tape over it, and that would create a pressure dressing, and that would work really nicely. Hang on, sorry. I'm gonna be careful.
I think you can just end
There
at
we go.
Christy. When you're at Christy, I think you can stop there, unless you want to go through the whole thing.
If it's whatever is easy for you, Sue. Do you want me to finish?
Sure.
I'll just finish.
Okay.
Okay, pelvic binder or sling. The use of a binder or sling for suspected pelvic fracture to decrease bleeding. And I put this in because it needs to go around the greater trochanteric process of the femur. And so it's a lot lower. You don't put it up around the iliac crest. It's a lot lower than you would think. And if somebody has that, you also have to do a lift instead of rolling them. Head trauma. Anticoagulation reversible table is now included in trauma treatment. We now have a lot of anticoagulated patients and most are elderly. We're living a lot longer and more active. So you've got to think that the person that you're treating could be anticoagulated. We have good anticoagulation medication now. Okay, the Glasgow Coma Scale. Some terms have changed. If you can't score a category, you use NT, not testable. The Glasgow Coma Scale came from the University of Glasgow in 1974 and is used worldwide. And here is a picture of it. A normal score is 15. And you can look at this, but the big change in this is the motor response. To elicit a motor response from somebody who appears to be unconscious, we are no longer supposed to use a sternal rub due to it causes soft tissue damage and the responses aren't predictable or reliable. So you now use, let me go to that screen, fingertip pressure, trapezius pinch, or supraorbital notch pressure, right below the eyebrow. With head injury, you can look at signs for skull fracture. This is battle signs, which is bruising behind the ear. And this is raccoon eyes. And these signs can take a day or two to appear. Spine and spinal cord trauma. It's now recommended to use the Canadian Cervical Spine Rule, CCR, and the National Emergency X-Radiology Utilization Study Nexus as a guideline to clear cervical spine injuries. So this is the first one, okay? And so first you think any high-risk things. Patient is over 65, a big dangerous mechanism of injury, or they have paresthesias in their extremities. If they have any of those, they have to have a C-spine immobilization and they need a CT scan. Any low risk fractures, or excuse me, factors. So any of these, if they have these, then they probably don't have a problem. Simple rear-ended motor vehicle accidents. They're sitting up in the emergency room. They are ambulatory at any time. Delayed onset of neck pain. That would be like somebody who perhaps fell forward and kind of had a whiplash of their neck and they were fine. And now today they hurt, the next day. And that usually is from, muscle pain, like their sternocleidomastoid muscles, and absence of C-spine tenderness. So if they are good there and they've been doing any of those, then you look and see if they can rotate their neck 45 degrees to the left and right. And if they can do that, then you can clear them. The one I like a little bit better is this one. It's a little bit more simple. Oops, sorry. There we go. So the Nexus criteria is neurological defect present. If they have that, they need to be immobilized and get a CT. Midline spine tenderness, altered level of consciousness, intoxication, or distracting injury present. For instance, if they have a femur fracture or something that's giving them a lot of pain, they may not realize that their neck hurts. Change in term, spinal immobilization. Term replaced with spine motion restriction. This is another thing like flail chest, right? You try to avoid the use of backboards over 2 hours to decrease the risk of skin ulcers. Musculoskeletal trauma. The use of tourniquet to control severe bleeding is now recommended, not a last resort. And this is my tourniquet video. And I included this because you may have to use it, although it's an unusual case, but you may have to use it.
Okay.
I came upon a skier who is unconscious. She's breathing, she won't wake up, and I see blood pooling from underneath her pants. So I'm going to explore the wound. And it looks like she's like squirting blood out of her femoral artery. So I'm going to hold pressure here, which is a pressure point on her femoral artery. I'm going to have somebody get the tourniquet. So someone's holding pressure. I've got my tourniquet. This is a life-threatening wound. She's lost a lot of blood. Before applying the tourniquet, always remember you can try direct pressure and see if that will stop the bleeding, but in some cases it won't, and you have to use your tourniquet, which can be life-saving. So you're going to apply your tourniquet while somebody's holding pressure there. You can hold pressure here at the, if you have two people, you can hold pressure here at the, over the femoral artery and over the wound. So you're going to apply it 2 to 3 inches above the wound, proximal to the wound. Tighten it up. And then you take this and you twist it until the bleeding stops. Then you secure it you tighten that down. If the patient was awake, you tell them that this is gonna hurt a lot, and once you put it on, we cannot take it off. Then you're going to label the time of day that it was put on. Some people will put, in Sharpie, will write a T and write the time on the patient's forehead, and then you need to get them to the hospital. You can apply a tourniquet for up to 2 hours without doing ischemic damage to the extremity. You never take the tourniquet off, ever. Thermal injuries. Okay, fluid resuscitation for burns has been adjusted. And they're doing it now per kilogram, how big the person is, but that's not really something you have to worry about. Huge fluid loss due to capillary leak you need to start IV fluid immediately or they can die from shock. And it's a lot of fluid, like an amazing amount. PCARIN traumatic brain injury algorithm. This algorithm is used to identify traumatic brain injury and a need for CT scan. Okay, so under 2 years old, altered mental status, scalp hematoma, loss of consciousness over 5 seconds, severe mechanism of injury, palpable skull fracture, and abnormal behavior per parent. And I've seen a couple examples of this. I had one kid who came in with his parents, but his friend was with him. And the friend said, well, maybe he wasn't wearing a helmet and maybe he hit a tree. And sure enough, the kid had a boggy spot on his scalp and he had a scalp fracture. And, he had a headache and vomiting. And he also had blood behind his eardrums. And then another one with the abnormal behavior was a day after the head injury, the kid seemed fine. And then the next day was kind of a bit staring off into space and kind of dazed and confused. Between 2 and 18 years old, altered mental status, loss of consciousness, history of vomiting, clinical signs of basal skull fracture, which would be like that battle sign, and the raccoon eyes, severe mechanism of injury or severe headache. Geriatric trauma, lower threshold to image elderly with these pre-existing conditions. Cirrhosis, coagulopathy, COPD, ischemic heart disease, and diabetes. They know that people with these conditions have a 2-fold increase in mortality. And then last, transfer to definitive care using the SBAR tool. And I think this is, they use this just trying to get people to be, to communicate more effectively. So the situation, what's happening, the background, the assessment, and the recommendation. For instance, they have midline C-spine tenderness. We've got them on a backboard. They need to be have more advanced care. And that's it.
Okay.
Okay,
Perfect.
Kathleen?
Yep.
That was just fantastic. Really,
Oh,
really
thank
good.
you.
Thank you. I've already gotten a bunch of good comments.
And the reason
Sue,
why I did it all the way through, Sue, is because then you don't have to splice it.
well, unfortunately, it's real important that we have the beginning and the end.